What if the hospital you go to, the care you receive, was shaped by history? Colonialism didn't just take land and resources, it shaped the healthcare systems we rely on today. They prioritized their own needs while neglecting indigenous populations. Policies like eugenics were often used to control and marginalize these communities. Historically, indigenous communities in Canada faced severe healthcare disparities. This is clearly seen in the doctor to patient ratio, where settler communities had approximately one doctor for every 450 people, while in indigenous communities, the ratio was one doctor for every 2,500 people, a stark reminder of the healthcare neglect that indigenous populations suffered due to colonial practices. The effects of colonial rule continue to shape healthcare worldwide. Here's how. In the Caribbean, colonial neglect left weak public health systems. Many nations still struggle with underfunded hospitals and doctor shortages. In Nigeria, under British rule, healthcare served colonizers. Today, underfunded hospitals and shortages of medical staff remain a huge crisis. In India, British policies privatized healthcare. As a result, millions lack access as private hospitals dominate the system. In Kenya, colonial rulers ignored rural healthcare. Today, rural hospitals remain severely underfunded and under-resourced. In South Africa, apartheid-era health policies still shape inequality. Historically, white areas have better hospitals while others remain underserved. Recently, the COVID-19 pandemic showed us that these legacies are still very much present. During the vaccine rollouts in 2021, wealthier countries secured the majority of the vaccines, leaving many low-income and formerly colonized countries struggling to reach even 20% vaccine coverage. To gain deeper insights into how these disparities are addressed, we spoke with Dr. Zoha Salam, a global health and epidemiologist expert. Dr. Salam will share her research-based solutions to tackle these deep-rooted issues and offer actionable steps for global change.
Yeah, political embargoes and sanctions are a huge one. For example, during COVID-19, there's a lot of embargoes that are put between the UN and other type of governing agencies that prevented the allocation and delivery of like really important medication. And we saw some countries struggling, obviously, with their mortality rates because of these sanctions put in place. Another example is like structural adjustment programs that were done to the World Bank and IMF in 1980s, and other types of predatory loaning schemes that supported countries once they've left colonial handovers. For example, Haiti is still in debt to France, even though that they repaid a large amount of sums over time, and this is another example. Also part of the structural adjustment programs, I forgot to mention, this often included clauses of having privatization of social welfare services, meaning people, organizations, or countries couldn't allocate towards building their healthcare infrastructure in any capacity. So that's an example. Another one that's really, really important right now is foreign aid. There's a lot of stipulations associated with foreign aid. For example, from the USA, there's something called the Global Gag Rule, or the Mexico City Policy, which essentially states that foreign non-governmental organizations like NGOs who receive global health assistance are prevented from providing legal abortion services. And with everything happening in America currently right now with the pulling of US aid, there will be horrific impacts on countries who rely on this. But it also calls into question about why exactly does the US, what have they done essentially to make everybody reliant on them, right? For sure. One of the things that comes up into my mind is medical education systems. A lot of the Western ways of doing medicine and also how medicine is taught as a curriculum is favored. And so you have a lot of individuals from other countries who are their degrees and education is not seen as comprehensive or valid, even though that they have a lot more comprehensive training compared to us. Another thing that's really interesting is patent laws and pharmaceutical monopolies. For example, a lot of countries are not able to manufacture or purchase medication depending on the policies that are put in place, which prevents them from having their own infrastructure, but also having their own health capacity. Another one, this is really, really core to settler colonialism, but is like built-in forms of eugenics and ableism within policy and laws. Even how we conceptualize health and think about what the ideal body. For example, slavery has a huge impact on medical history and how we think about health and bioessentialized race, essentially. Yeah, this is a really interesting one. So we have to understand that ethics boards are a huge deterrent for conducting research in a multitude of ways. They are biomedical in nature and should be restructured to account for epistemological diversity and community involvement too. For example, if you have a qualitative piece of research that's being put through the ethics board's pipeline, you're going to receive a lot of comments that are irrelevant, essentially, even the form that you have to fill out as part of that, right? So the other thing that comes to my mind is improving funding lines. For example, some federal grants we have, you need certain affiliations, and getting community members on board is really difficult because they may not meet certain type of qualifications. And also the other very most important thing is ensuring compensation is reflective of the labor that is being provided, and most oftentimes funding buckets will not recognize that or allocate for that. The third thing that comes to my mind for this one is rethinking academic outputs and making them more valuable in other ways. For example, how is authorship to be determined and encountered? Thinking about like 5 different things, like one thing that comes to my mind is educational reform, making sure that courses in certain forms of curriculum are mandatory, like a mandated course on racism and health, or Indigenous health, or Black health. It should not be seen that our courses are, voluntary, or should be seen as an elective, especially because that tells you how much value that they bring to the table within the curriculum that you built. Number 2 is voicing up. It seems very easy to say, but when you create a culture of change by saying that something's unacceptable, it really does shift the needle quite a bit. Number 3 is organizational, focusing on internal, reflecting a lot on your internal oppressive policies, and that reflects a lot on how you actually end up engaging with people, because oftentimes whatever the dynamics that you have internally within your organization reflect outside on how you engage with. For example, if your organization is very hierarchical, something that ends up happening is that you will reflect in depending on who you end up inviting to the table for a community issue. For example, you may only end up inviting people who are the boards of directors or the founders of organizations, versus actually people who have lived experience of an issue, right? And all this, I can sum this one up, is you need to clean your house first before you end up going outside of your house. The one after that I'm thinking about is just mobilizing in the way of unionizing your workplaces for better income and workforce rights. And this will let you to have options for professional development and different ways of engaging and learning as well. And lastly, I think this is a really important one, especially as somebody who's racialized. Representation will not save us. While oftentimes we think about diversifying the field as a very easy call and action to fixing our problems, not all skin folk are kinfolk, as the verbiage goes, right? There are people who have very oppressive identity, oppressive attitudes and beliefs, and even though that they may belong to a marginalized or actively marginalized community, but it highlights that racialized individuals, or individuals of any other background, we're not a monolith. So just because you have somebody at the table who looks or belongs to a certain group, it doesn't mean entirely that this is an individual that will help their community as well.
Colonial legacies still shape global healthcare systems today, but change is always possible. Together we can create a more just and equitable future. It's time to challenge these systems and decolonize health.